big role. And last year she did one on shipping, and here she has construction. Now we're going to look at why the American healthcare is so screwed up and what we can do about it. So please come out, Dan Monroe and Mario Schlosser. The statistics are shocking about how bad American healthcare is vis-a-vis other countries. And in a minute, Dan will recite those. But the fact is that it's unconscionable. It's a huge cost that we really shouldn't have to bear as a nation and as American business and as consumers and people who are trying to stay healthy. All of the above are not working correctly in this country. And what we have up here are two experts on that. And with one is a practitioner and the other is a very polished observer. Mario Schlosser is the CEO of Oscar, which is a company, an health insurance company that has a lot of ideas about how to do things more efficiently using technology. Essentially, it emerged as a response to Obamacare. And so he has a lot of understanding about what's really happened there, what it's intended to do, what it might do, and we're going to hear a little bit about that. He famously, his partner is Josh Kushner, so it gets a little extra coverage because of that. And recently, the two of them wrote an op-ed at Axios where they basically said, you know, that the president's activities were having both positive and negative effects on Obamacare. But just the fact that you even implied that there was a little negativity there made a lot of news because Josh signed it along with you. Dan Monroe is a writer who has written about a lot of tech-related stuff and other topics, but has become really an expert on healthcare and American healthcare policy reform in the last couple of years. He wrote a book in 2016 called Casino Healthcare, which is a powerful indictment of the American system and an argument for universal coverage. And I won't use other buzzwords because we'll talk about the buzzwords. But quickly, Dan, what are the statistics about how bad it is here?
Yeah, so probably the first and easiest one to kind of grab a hold of is the fact that the U.S. healthcare system, as an economic unit, if you measured it, is basically the size of Germany's GDP. And even abstracted one level lower than that, just the budget for HHS, Health and Human Services, which is now the federal government's largest single department, just HHS is the GDP basically of Spain. So those two components coming together give you a sense of the size of the cost issue that I reference as being both a 4-alarm fire, a Category 6 hurricane, on the Richter scale 9.0.
And in the piece that you wrote for us in the last issue of our magazine, we had a chart that showed health expenditure per capita on one axis and lifespan on the other axis. And it is worth looking at that because it is so shameful. The U.S. spends so much more money and gets so much less for its money than any other major country. You know, Japan, UK, all these countries spend less and people live like 4 years longer, 5 years longer. It's just crazy. And we spend dramatically more than any of these other systems per capita. So what we're here to do is to talk about what can we do about the rising cost of healthcare. So Mario, talk to us about what Oscar is trying to accomplish.
Yeah, I think if I sort of like at a high level think about in abstract healthcare costs, there's really three components that go into healthcare costs. There is risk of population, there is utilization per risk, how often do you go to the doctor for a given condition, and there is unit costs in essence. So for every utilization, what are you going to pay? When we compare the US to other countries in the world, when we stay at that abstract level, then from a risk perspective, the population isn't that different. So in fact, the US population is on average, median age is 3 years younger than OECD countries, rich countries in the world. From a utilization perspective, we go to the doctor a little bit less, we get discharged from hospitals a little bit less than the rest of the OECD countries. And so most of the issue is in unit costs. That goes right back to the fundamentally incorrectly set up incentives in the healthcare system. Every provider is in every insurance company's network. There's very little value, competitive pressure on the value chain. And the reason for that is that as an end user, you don't really pay for your own healthcare and don't have much choice in the matter of how much you want to pay for that healthcare. So the way we address this sort of like too confusing and too costly system is in 3 different ways, starting with consumer engagements. We want Oscar to be the organizer of your healthcare. We care routes about 45% of all first-time physician visits. So any Oscar member who has a first-time physician visits, we sort of like can prove that we were the ones who recommended you the physician that the member ended up going to. We do lots through telemedicine. About 70% of all routine rashes and infections are now done through telemedicine for Oscar members. Engage members very differently, become the entry point to healthcare. We build different networks. For example, we just launched a healthcare plan with the Cleveland Clinic. We share risk 50-50 between us and the Cleveland Clinic, which is the perfect way in which you want to share.
You mean financial risk?
Financial risk, exactly, which is the perfect way in which a provider system and an insurance company basically acts in a cooperative and coordinated way, because you both share fully in the upside and the downside of the outcomes that you create. And we do all this on a very different technology stack. We talked about this a bit earlier, but right now, if I wanted in healthcare to do what Amazon, Uber, others in consumer industry are doing every single day, which is pricing based on demand and supply, I couldn't do it as an example because the underlying infrastructure isn't there. As an example, the typical claims formats by which a physician practice submits a claim to an insurance company doesn't have the time of day in that format. And so I couldn't actually give you discounts if you went to a doctor in off-peak hours. Something as basic as that.
And that's sort of a rigidly predetermined form that can't easily be changed.
That we can change it because with the insurance company, the thesis behind Oscar from the beginning was the insurer is in a good position to become that organizer of your individualized, consumerized, personalized healthcare because the insurer controls the flow of data and the flow of money throughout the healthcare system and therefore can reroute those in smarter ways.
So what is the fundamental incentive for a consumer to use Oscar versus another insurer?
Better experience and a lower price, as simple as that.
So it's lower price, but it's also a more technologized, more user-friendly, and consumerized experience. Because I know consumerization is a key thing that you advocate that is basically absent in the American healthcare.
Exactly. We essentially go to the member and we say, we are going to build you a more customized, more narrow healthcare network. We work, for example, only with the Cleveland Clinic, not with the other hospitals in Cleveland, Ohio. We work only with Mount Sinai in Manhattan, not with the other hospitals in Manhattan. We therefore get lower unit costs from those providers. But then, because we have your attention as a member, have a better, more scientific way as well to get you to the right provider for the right reason. Simple example again, if you go to the typical insurance company, you can try this today, go on the web, search one of the big incumbents, and you look at their physician finder. Very simple trick. You'll see they will distinguish about 100, 120 or so physician specialties. That isn't enough to properly care routes, the various conditions you may have as a member. You need about 400 different specialty distinctions. And so we can build those and that tree, that hierarchy of medical sort of like concepts in conjunction with our healthcare systems because we built a narrower network. In exchange for that, get better unit costs.
Just quickly, how does Obamacare fit into this?
In a very simple way.
As quick as possible.
Yeah, very simple way. It was essentially the first really consumerized, individualized markets where you didn't have to go through your employer or through a bunch of other middlemen to select your healthcare. You can pick one plan, actually stay with it for a long period of time. And so in my opinion, it sort of like points, whether the ACA survives in this current form or not is almost irrelevant. It points into a future where you as an individual can vote with your feet as to which insurance company and which healthcare subscription package, that's what insurers really are, you want. For us, it means about 40% of our members in New York, for example, have come through word of mouth now. So we can have viral growth in a way you would never have it if insurance stays in non-consumer products, if you get it through the employer, et cetera.
What percentage of your customers now, individuals, are coming through Obamacare?
I'd say it's about 90% or so. We have an employer market or an employer plan now as well that's starting to grow. But it's about 90%.
Effectively, at this point, any individual who goes to Oscar is, in effect, using ACA, yeah.
That's right. I mean, so if you ask me how they come to us, I'd say maybe about 25% have come through a government website. You know, the rest comes directly to hioscar.com. You can sign up there in 5 minutes, or through one of our people on the phone, etc.
Okay, Dan, what is your fundamental prescription for reform? Because I know you have a pretty good way of synthesizing this.
So I think in a lot of ways it's hard to see this from the vantage point of where we are today. There's a tendency to want to think of healthcare reform, systemic healthcare reform, as a single piece of legislation or a single administration. And the reality is that it's actually going to take longer than a single piece of legislation or a single administration. The fact is it's probably a 40 to 50 year horizon or timeline for what I would call systemic healthcare reform. We're in the middle of that timeline.
Wait, well, what's the end point, obviously?
So the end point ultimately is, if you look at other industrialized countries, is to get to a model that revolves around universal health coverage. And I make that distinction of using the word coverage because there's a tendency to wrap universal health care and in effect blanket that as the solution, when universal health care can be confused, and often is confused intentionally, with single payer health care as the only prescription that is on the road ahead. And the fact is, we can get to universal health coverage without single payer. We can do it as a multi-payer model.
Which clearly seems to be what this country wants. But the bottom line is, you take it as a given, an inevitability, that we will get to universal coverage, which seems so ludicrous that we're not there already, which every other industrialized country is already at. But where do you come up with the 40 to 50 year timeline?
So, yeah, in a sense, you look at the history of other countries that have duplicated this or that have gone on their own trajectory and their own timeline. And the best example is probably Canada. And it took Canada literally about 40 years to get to a process of universal health coverage. And I wouldn't recommend necessarily single payer. I would absolutely recommend a multi-payer model for our system because it's more of a cultural fit. We're not a country that is likely to embrace fully the concept of single payer, in part because there's too much of an overhang politically with the idea of government-run, government-owned health care. We're not culturally fit for that kind of a model, and we don't need to be in order to get to universal health coverage.
So that all sounds right to you?
That's exactly right. Yeah, you need a system where the end consumer knows what he or she is paying and what value he or she is getting, and where I have the power of putting pressure, competitive pressure on the entire value chain. And that's completely absent right now. If the employer with a big tax break pays for a broad network where no provider has to compete for any value, you end up in a fee-for-service model where, you know, insurers pay for every single thing on the bill. You end up in the system we have right now where every single actor in the system has an incentive, because you earn a % of the overall cost, for the cost to go up. And that's how you end up with, I think, the CAGR, annual growth rate of just employee contribution to employer-sponsored healthcare between 2010 and 2016 has been 10%. But
10% annual growth in what individuals pay for their health insurance?
Contributes to the health insurance to the employer. Wow. And the employer's cost has gone up as well.
Okay, really quickly, how do you both feel, and how positive has it been that Bernie Sanders has actually started talking and created almost a movement around this idea of Medicare for all, which seems to me to be a very positive sign in that it has actually gotten some traction?
Absolutely. In fact, I'm thrilled in the sense of the kind of education that that has brought to American consumers and the American population at large, is conceptually understanding the idea of universal coverage. I'm not convinced, and in fact, Lawrence Lessig had a great quote referencing Bernie Sanders in this specific way, when Lawrence said, you know, everybody rolled their eyes when Bernie said Medicare for all. And it wasn't because it was a bad idea. It was because everybody understands that in this money-driven political system, it'll never happen. And that's a key element of the change that Bernie is bringing in the sense of the overall dialogue to the nation.
But it's something that ordinary Americans understand, and they don't understand single payer, single pricing. Right. They don't even understand universal coverage. But Medicare pretty much everybody understands. What do you think?
Well, I think you have one simple issue in the U.S. economy right now, and that is that healthcare is 20% of it. You know, you see this very nicely. You drive into Pittsburgh, and there's the U.S. Steel Tower right in the middle, and that, you know, obviously was the headquarters of U.S. Steel when people were still manufacturing stuff in the country, and it's now full of hospital administrators.
Is that right?
Yeah, it's the UPMC system, and it's not even a hospital, it's just administrators, basically. And that's what better metaphor for sort of like the switch of the shift of the economic forces you've had in this country. And if you want to get the cost of the system down, somebody's cost is somebody else's revenue. You're going to have to shrink a whole bunch of economic activity back down to where it ought to be, and that means capacity reduction. Right now, you have an overbuild of MRI machines, and you have an overbuild of emergency rooms in this country. That's going to have to shrink more towards primary care, more towards telemedicine, more towards even, you know, nurse practitioner-based practices. And that's a very, very painful process when I think it's a Stephen Brill quote, when the highest paid guy in every community is the hospital CEO. And so, yes, I do think that's like Germany, for example, we talked about this earlier, the way they do it is they have a multi-payer system. You know, I joined an insurance company in Germany. I'm from Germany originally because it had the name technology in the name, literally.
So
that's
that
the only thing
attracted
I knew about it. You know, there were not any more technology fights than anybody else, but I like the name, basically. But they limit provider pricing. The government says this is what you're going to charge for hip surgery, and that's it. You can make money at this level if you're efficient. If not, you got a business. And so that's how other countries choose to basically rate limits the consumption of healthcare services.
Right. Really quickly, because I want to go to the audience, but one of the great points you made, Dan, is that, you know, we always hear about the UK system as, you know, kind of the alternative, right? That's the universal coverage, single payer that we ought to be like, people seem to think. You reject that.
Yeah, I do. In fact, in part because I don't think culturally, again, we're a good fit for government-run single-payer system. And the good news is that we don't need that in order to get to universal health coverage.
And that's the distinction between UK and Germany, is it's government-owned hospital systems, everything in UK. In Germany, it's essentially a commercial system the government highly regulates, especially in terms of pricing.
Just in terms of pricing,
Right.
everything else is basically free markets.
Yeah.
In Germany, 10% GDP healthcare, UK 9%. You know,
Okay.
so there is a bit of a difference, but not that much.
I want to talk tech. We haven't gotten to that, but who has questions or comments? And let's get the lights up so we can get audience any thoughts or questions. Where are you pointing? Okay, over here first, and then we'll go to Josh. Yeah.
Roy Smythe from Phillips. This question.
An expert.
This question, not an expert.
Yes,
there are
you
no
are.
experts as it turns out. This question's for Dan. So Dan, wouldn't you say that universal health coverage is necessary but grossly insufficient? I mean, just giving everybody coverage and layering that on top of a market-based healthcare delivery system is really what we have. You're not really fixing the delivery of care, you're just insuring everyone.
Well, yeah, I think in a lot of ways what you're doing, though, is you're removing a key incentive that's at conflict with ultimately what healthcare is. Healthcare is not a consumer product.
That's how we treat it here.
It's how we treat it, in part because we've done it with other industries, and we assume that we can do it simply in healthcare by tiering pricing. And the whole basis of tiered pricing is assuming that you can extract and maximize the revenue and profits associated with tiered pricing. We do it for airlines, we do it for hotels, we do it for cars, we do it for appliances, we do it for mattresses. So we do it in all these other industries, and the assumption has been that, gosh, we should be able to do that in healthcare. The trouble that it creates within a fee-for-service model is that when you have inelastic pricing, everybody drives to a quarterly beat. And it's the quarterly metronome that's driving our healthcare system to make choices that aren't in the long-term interest of both the country nationally and then in terms of our individual health, which is the real risk.
If I could just make, and please feel free to jump in, but the observation that I would make based on the fact that Techonomy has been really getting our hands dirty in this area for a couple of years now, that maybe I'm surprised was a revelation, but the real issue is the U.S. is a fee-for-service ecosystem, and the services are priced pretty much based on some weird factors that really don't have anything to do with the health implications, the outcome of the pricing. So we are not paying at all for health. We are paying for services, which is why there are so many extra emergency rooms, so many extra EMRs, et cetera, et cetera.
Yep. Yep, exactly. If I may add something to this as well. In a system where no single actor is responsible for organizing your healthcare or for the outcomes that the system produces, nobody becomes any good at managing all these various services and coordinating them. Here's a good example from just recently. CMS, the kind of federal regulatory body, has a program in Medicare called ACOs. These are sort of like physician practices that basically start taking some risk for the outcomes they produce, and you can either go fully at risk, meaning you have share upside and downside with CMS, or you can sort of like do a light version where you just share in some savings, basically. And 95% of all these ACOs across the country are merely in this shared savings thing, and CMS gives them more money than they actually save. In other words, if somehow somebody out there had figured out the administration and management of your care, which service at what point in time, ends to end, basically to get you healthier at lower costs, they would be levering up on this like crazy. This is like a hedge fund manager who doesn't want to put his own money in his own funds, and that is what you get in a fee-for-service system where the consumer has essentially no role in the setting of cost and in the demanding of value.
Okay, quickly, Josh.
Question is, do we have to agree first as to whether or not healthcare is a right or a privilege to achieve truly sustainable healthcare reform, given that being healthy is a choice, but we're now trying to decide whether or not to regulate access to help if you're not healthy? Do we have to agree to that first before we can reform? And what does that do to your time horizon?
I mean, it's almost like I almost think that I can go into lots of philosophical thoughts here, but the fact of the matter is we spend way more than any other country on earth on healthcare. And we probably are treating it the least as a right, So clearly whatever we have been doing has not been working. Somehow we don't let people die when they get sick. They can go to the ER, get care there. It's horrible, suboptimal care. And it ends up being a lot more expensive than if we probably organized a system that invests more in your long-term future and health. The other thing, by the way, one additional thing to that as well is right now no insurance company is able to really invest in your long-term health because once you change jobs and employers, you change insurance companies, and boom, you're somebody else's problem or accretive investments, in a sense. That all goes back to the same thing. So my opinion, whatever we've been doing, treating it not as a right for the most part, has not been working. We ought to try something different.
And to your point, Atul Gawande wrote a recent article for the New Yorker that talked about this exact point. And I think, yes, ultimately we need to come to a polarity or plurality that healthcare is a right.
Two quick things I'd like to just hit before we wrap, and we do have to pretty much run out. And one thing, Eric Topol, who's a great thinker on this, and I hope he's in the audience, but said at the section on data and ownership of data earlier was, we don't currently put your data all together, and it's, if we do, which is a relatively simple technological challenge,
Yep.
we would be able to get radically improved health outcomes.
Yep.
And the reason we can't do it is because of the organizational inefficiencies of the system. And then I wanted to lead into the point you made to me, which I found shocking, because you're really making some really disturbing discoveries by operating as an innovative insurer. And the one you said to me about the names, quickly, the doctors' names. Right. Just give us quickly that.
Well, one of the big systems we're working with, has an Epic installation. Epic is the most kind of popular EMR system in hospitals and everything. And basically identify their doctors in that system by first, last name combinations, by text strings. That's how the matching of physicians still works. In other words, that's as if Facebook knew no difference between various John Smiths.
There's 30 David Kirkpatricks. Yeah.
In a sense, exactly. And so it just shows the very, very crude setup of data systems and therefore lack of interoperability that you still have in healthcare nowadays. And it all goes back to the fact that none of the formats in healthcare, data formats, have ever been devised for any kind of clinical interoperability or clinical payload. It's all purely for payments. Hence also, that's why you don't need a time of day on a claim, So that's the other thing I think I mentioned earlier, which I found pretty crazy. The government basically tells insurers in Medicare Advantage, an individual, small group, you got to risk code your members. You got to tell me how risky your population is. That can be done by pulling sort of charts from physician practices, which basically has to be done manual. You send the company into physician practice that takes photocopies, and the majority of these records gets put in a, sort of like gets scanned, but not actually optically character recognized. And so there's data about your physician notes and your care history sitting in a server somewhere, but it's all sort of like in image formats. It's not really electronic, digitized, so it could be used for better care management and things like that.
Okay,
It's also
is Eric in the room? Where are you? Okay. I just want to give you an opportunity, if you have any final observation, because you're an acute observer of this whole situation.
Well, I think the unified points that I got from Mario and Dan is about that it's really about pricing and the cost of, it's not even care, it's health services. We don't give care. That's a part of the problem. But what I think is hasn't been touched on enough. One is that there's a third of all this 3.3 trillion that's total waste, which there's some things that are being done about that. And then there's another big chunk that would be if we use technology, which the medical community doesn't want us to use because it challenges the incumbents and all the cost structures, like getting rid of hospital rooms by remote monitoring, getting rid of sleep labs, which are complete ridiculous drain of costs, number one revenue centers in most hospitals, and things like that. We don't challenge the medical community with respect to these practices, and so there hasn't really been a movement to deal with the cost problem.
Well, we would love to help get a movement started, and I hope that you'll stay with us and you guys will both continue to be part of our deliberations, because it's just inexcusable what the situation is today. And thank you so much, Roy and others, for participating in these discussions. And I just want to add also, tomorrow we have Mark Bertolini, CEO of Aetna, who is one of the good guys and really has thought about a lot of these same things. So that's our closing interview tomorrow afternoon. So thank you so much.